Welcome to our video on arthroscopic repair of TFCC by outsiding technique. Me and my co-author have nothing to disclose that can be relevant to production of this video. Case detail: patient is 47-year female, right head dominance, had history of trauma to right wrist, following which she developed ulnar-sided wrist pain. It was not responding to conservative treatment. On clinical examination, her grip strength was reduced and she had a pain during pronation and foveal sign was positive. Patient had difficulty in carrying out activity of daily living. Her initial X-ray was normal and MRI suggestive of peripheral foveal tears. We plan to do arthroscopic capsular repair of TFCC using outsiding technique. We use convex inverted traction set. Patient is in supine position, shoulder abducted, elbow flexed and forearm pronated. This is a schematic representation how to make a portal on dorsal side of a wrist. Portals are based on location of extensor compartment of wrist. We use 3-4 portal as a weaving portal and 4-5 as a working portal. And 3-4 portal is made by palpating listus tubercle and 4-5 portal by palpating distal radial ulnar joint. Now keep your thumb on listus tubercle and flex the thumb. The tip of thumb is your 3-4 portal. Similarly, at distal radial ulnar joint, keep your thumb and flex. The tip of thumb is at 4-5 portal. 1 cm distal to 3-4 portal, there is a mid-carpal radial, and 1 cm distal to 4-5, there is a mid-carpal ulnar portal. We use 2% lignocaine for portal specific anesthesia and patient is wide awake. Then we incise the skin with 50 number blade and we use curved hemostat to perforate the joint capsule. Just make a small window to accommodate the scope. Then introduce 1.9 mm small joint scope. Then under vision, make a 4-5 portal by introducing the needle and make a portal similar way like a 3-4 portal. Then make a diagnostic round starting from ulnar side to radial side. Look for bony landmarks, then look for the soft tissue landmarks. Now at ulnar side, there is a loss of trampoline and TFCC can easily lift it up. That's the hook test positive. Then make a debridement of synovitis and debridement of scar tissue at TFCC. Presence of synovitis indirectly indicate that there is a peripheral tear in TFCC. Then we started our repair with 23 gauge needle and PDS 30 suture. Pass the needle from outside the skin and make a good bite of TFCC and retrieve that suture through 4-5 portal. Then pass another needle like a suture lasso and take out this lasso through 4-5 portal. And with the help of this lasso, take out the suture from 4-5 portal into the joint and then out. After passing this suture, we found it was still unstable. So we decided to pass another suture just below the 4-5 portal. After retrieving the suture through 4-5 portal, we tie a knot. Before making a knot, look for dorsal sensory branch of ulnar nerve, and similarly on dorsal side look for any dorsal tendon entrapment. Before you make a knot, all traction should be released and wrist should be ulnarly deviated, and then make a tight knot. Then again check arthroscopically. TFCC is sitting nice and taut. Also check clinically for ballotment. And the most important, ask patient to move the finger. Since the patient is wide awake, which indirectly indicate that you have not damaged any extensor tendon. I use sterile step for closure of the wound. Postoperatively, forearm is put into the sugar down splint, where patient can start elbow range of motion from day 1. And forearm rotation are started after 4 weeks, and then gradually it is increased to achieve as close to as normal side. And athletic activities are encouraged after 3 months. Post-operative 10 days, portal sites are healed with good cosmetic appearance. Thank you for watching the video.